Hi everybody, and welcome to our module on metabolic alkalosis. In the video on acid-base principles, I talk about the 4 categories of acid-base disorders, and in this video we're going to focus on the third one, metabolic alkalosis. So in a metabolic alkalosis, the pH will be above the normal range, so it will be greater than 7.42. And in a metabolic alkalosis, the primary abnormality is an increase in the plasma bicarbonate level. If you look at the Henderson-Hasselbalch equation at the bottom of the screen here, in a metabolic alkalosis, the serum bicarbonate level goes up. That's the primary abnormality. That causes the pH to rise. And then as respiratory compensation, there will be hypoventilation, which will cause the PCO2 to rise as well. And that will offset the increased pH from the alkalosis. And so just to emphasize these points, remember that hypoventilation is the normal respiratory compensation to a metabolic alkalosis. This will cause an increased PCO2, which will lower the pH back towards the normal range. Shown on this slide are some of the important causes of metabolic alkalosis, and we'll go through all of them in this video. But you should know that the way most patients with metabolic alkalosis are identified is by finding a high serum bicarbonate. We check the plasma bicarbonate level routinely. It's part of the Chem7 measurements that include sodium and potassium. So this is measured almost every day in patients in the hospital, and you will frequently find patients where the bicarb is high, and usually those patients have a metabolic alkalosis. We don't routinely do a blood gas to check the pH, so you won't often know that your patients are alkalotic, but when you see that the bicarb is high, that means your patient usually has an alkalosis. And in hospitalized patients, number 1 and 2 here are far and away the most common causes. Most patients in the hospital with a high bicarbonate are either losing contents from their GI tract or they are volume contracted and have a contraction alkalosis. Okay, so let's talk about gastrointestinal acid loss as a cause of metabolic alkalosis. This is very common in ill patients. Patients who are vomiting will lose acid from their stomach, or patients who are placed on gastric suction for whatever reason. Your parietal cells in your stomach secrete hydrogen chloride, and so when you lose stomach contents for any reason, that causes a loss of protons and therefore an alkalosis. Importantly, because the parietal cells also produce chloride along with protons, any patient who's losing acid from the stomach is also going to lose chloride, and therefore they will be hypochloremic. And then finally, patients losing GI acid are also hypokalemic. That's because there's potassium in your stomach. So putting this all together, patients who have GI acid loss for whatever reason are going to have a hypochloremic, hypokalemic metabolic alkalosis. So like I told you before, the number 1 and 2 causes of metabolic alkalosis are GI acid loss or contraction alkalosis. Now let's talk about the second one, which is contraction alkalosis. Anytime you lose fluid from the body, you're losing free water but also sodium and chloride, and this causes the effective circulating volume to fall. When this falls, the RAS becomes activated as well as the sympathetic nervous system, and this has a couple of effects that lead to alkalosis. First of all, more bicarbonate is reabsorbed in the proximal tubule. In addition, acid is secreted in the collecting duct. So the bottom line here is any patient who is volume depleted for any reason, this could be because of vomiting, this could be because of hemorrhage, those patients will develop an alkalosis, and because their volume is contracted, it's called a contraction alkalosis. Now just a side point here, when I was in training, I was always taught that the cause of the contraction alkalosis was RAS activation and sympathetic nervous system activation. There is newer data that says the true cause is actually chloride depletion, because remember, volume in your body contains free water, sodium, and chloride. So anytime you're volume depleted, you are also chloride depleted. And there's data that says low volume leads to low amounts of sodium chloride in the total body, and that if you replete the chloride alone, that can resolve the alkalosis. So I just tell you this in case it comes up on rounds. They're unlikely to ask you the mechanism of contraction alkalosis on your board exams because it is something that is still not completely understood. So shown on this slide are some of the common causes of contraction alkalosis that you'll see clinically. So anyone who's vomiting is going to be volume contracted, and that can lead to contraction alkalosis. In addition, as we just talked about, when you're vomiting, you lose stomach acid, and that also causes an alkalosis. Diuretics cause volume depletion, and that can cause a contraction alkalosis. In fact, when you're treating patients with diuretics and their bicarbonate level starts to rise, that's one sign that they are becoming dry, and you may be over-treating them with diuretics. Patients who have heart failure and cirrhosis have low effective circulating volume. So even though these patients may be swollen, heart failure patients can have edema, or cirrhosis patients can have ascites. They have total body fluid excess, but their arterial system is underfilled, and therefore they behave as if they're in a volume contracted state. So you can see a contraction alkalosis in these patients as well. Next cause of metabolic alkalosis is hypokalemia. So the basic principle here is that in many cells in our body, potassium and protons can be exchanged for one another, and therefore protons can shift in and out of cells, and so can potassium. So anytime the potassium level is low, that will cause more potassium to come out of cells and more protons to go into cells. And when you lower the proton levels, you cause an alkalosis. Therefore, any patient who is hypokalemic can develop an alkalosis, and vice versa, any patient who is alkalotic will often develop hypokalemia. Next cause of metabolic alkalosis is the milk alkali syndrome. So the milk alkali syndrome is a triad of hypercalcemia, metabolic alkalosis, and renal failure. And it's caused by excessive intake of calcium and some alkali, which is some form of base that can raise the pH. Usually it's calcium carbonate or milk because calcium carbonate is alkaline. And years ago, patients used to take lots of calcium carbonate for dyspepsia. This is very uncommon in the modern era because we have proton pump inhibitors. But in the time before PPIs, patients would take lots of these antacids for stomach upset, and sometimes they would take too much calcium carbonate, and that would cause the milk alkali syndrome. So what happens in the milk alkali syndrome is all that calcium that the patient is taking in causes hypercalcemia. And one thing to always remember about hypercalcemia is it makes people pee like crazy. So anyone who's hypercalcemic for any reason is going to develop polyuria. There are a couple of mechanisms for this. The hypercalcemia inhibits the reabsorption of sodium, potassium, and chloride in the thick ascending limb of Henle. In addition, hypercalcemia blocks ADH-dependent water resorption in the collecting duct. So through both of these mechanisms, patients start to urinate like crazy when they're hypercalcemic, and this causes volume contraction. So now what you have in the milk alkali syndrome is a patient who has volume contraction, which causes an alkalosis, plus they are taking alkali in as part of the calcium carbonate antacid. So this combination leads to a potentially raging metabolic alkalosis. And then because the patient is volume contracted, the glomerular filtration rate falls and the BUN and creatinine rise, and that's how these patients develop renal failure. So through this mechanism laid out on the slide, patients who take lots of calcium carbonate develop the triad up here. The main problem is hypercalcemia causing polyuria and volume contraction plus alkali, making for a significant metabolic alkalosis. Next cause of metabolic alkalosis is hyperaldosteronism. So patients that have primary aldosteronism have overproduction of the hormone aldosterone by the adrenal glands. This can happen for one of two reasons. There can be generalized hyperplasia of the adrenal glands with overproduction of the hormone, or there can be an adrenal adenoma which is producing aldosterone, and when this happens, this is called Conn syndrome. But through whichever of these mechanisms, if you have overproduction of aldosterone, you're going to get an excess of aldosterone effects. So let's review what aldosterone does. So let's imagine this is the collecting duct of the nephron and urine is exiting the body in this direction. There is a sodium channel in the collecting duct called the ENaC, which pulls sodium from the urine. It gets the name ENaC because this stands for epithelial sodium channel. And what aldosterone does is activate the ENaC so that more sodium is pulled from the urine. So that's one of aldosterone's effects, is to pull sodium from the urine. Now sodium is positively charged, so when it leaves the urine, there is a negative charge left behind, and that negative charge is going to draw in two things. One is potassium, which is positively charged, and the other is protons, which represent acid. So overall, the net effects of aldosterone are to promote sodium resorption from the urine, and then also to promote excretion of potassium and acid into the urine. So when you have excess aldosterone effects from hyperaldosteronism, there will be an increased secretion of protons into the urine. This will cause a metabolic alkalosis. There will also be hypokalemia because of excess potassium secretion. And because of the sodium retention, there will be increased fluid in the vascular system, and this will lead to hypertension. The diagnosis can be made by measurement of the plasma aldosterone concentration and the plasma renin activity. The aldosterone concentration will be high, obviously, because this is called hyperaldosteronism. And renin activity will be low because the kidneys are trying to dial down the renin-angiotensin-aldosterone system, but they are unable to do so because you have an overactive adrenal gland producing too much aldosterone. And the treatment is to use drugs like spironolactone and eplerenone, which block the effects of aldosterone. In addition, if patients have an adrenal adenoma, surgery for the adrenal adenoma can be curative. So primary aldosteronism falls under a heading of a couple of rare causes of hypertension called low renin hypertension. In all of these disorders, as the name implies, the level of renin is going to be low. And the reason it's low is because there are too many aldosterone-like effects, in other words, too many mineralocorticoid effects causing hypertension. The kidneys are sensing this and dialing down the level of renin release, but this is ineffective and it's not bringing down the blood pressure. So despite the low renin level, these patients still have hypertension. So primary aldosteronism is sort of the classic low renin hypertension condition, but these other ones here are rare mimics of primary aldosteronism, and we'll talk about those now. Little syndrome is a genetic disorder where there's increased activity of the ENaC. This is that epithelial sodium channel we talked about earlier, whose activity is increased by aldosterone. So when there's an increased activity of this channel due to a genetic disorder, the body's going to behave like it always has too much aldosterone around. This presents in juveniles, usually it's young children or young adults, and it has a similar clinical syndrome to hyperaldosteronism. These patients present with hypertension, hypokalemia, and a metabolic alkalosis. So you should think of Little syndrome in any young patient who has hypertension and hypokalemia. And the way you can distinguish Little syndrome from primary aldosteronism is that the aldosterone levels are low in Little syndrome. Remember that we said in primary aldosteronism they are high. And the treatment for Little syndrome is a drug called amiloride. It's a potassium-sparing diuretic, and it directly inhibits the ENaC channel. Our next cause of low renin hypertension is SAME, which stands for Syndrome of Apparent Mineralocorticoid Excess. In order to understand this disorder, you need to appreciate that renal aldosterone receptors can bind cortisol. However, they usually don't because cortisol in the kidneys is converted to cortisone by renal cells. If you look at the bottom of the screen, in the kidneys there is an enzyme called 11-beta-hydroxysteroid dehydrogenase, and it converts cortisol into cortisone so that there's usually not much cortisol around to bind to aldosterone receptors. So in patients with SAME, they are deficient in this enzyme, and therefore there's lots of cortisol hanging around in the kidneys, and it's going to bind to aldosterone receptors and produce aldosterone effects. So SAME presents in children or adolescents, and it looks just like hyperaldosteronism. These children will have hypertension, hypokalemia, and metabolic alkalosis. Just like Little syndrome, it can be distinguished from primary aldosteronism because the aldosterone levels will be low. And the treatment is similar to Little syndrome. You use potassium-sparing diuretics like amiloride or spironolactone. Sometimes dexamethasone is used because this suppresses cortisol production, and therefore there's less cortisol around to bind to those receptors in the kidneys. And then the final low renin cause of hypertension is licorice. Licorice contains a steroid called glyceretinic acid, which has a weak mineralocorticoid effect, so it can somewhat mimic aldosterone, and in addition, it inhibits the renal 11-beta-hydroxysteroid dehydrogenase enzyme, similar to what happens to patients with SAME. So through both of these mechanisms, you can get mineralocorticoid effects, and that can cause symptoms similar to primary aldosteronism. You have to eat large amounts of licorice to do this, but these patients can end up with hypertension, hypokalemia, and metabolic alkalosis. But once again, the plasma aldosterone level will be low because these patients do not have hyperaldosteronism. The last two disorders we'll talk about in this video are Bartter and Gittleman syndrome. These are very rare congenital disorders that occur in children, and they cause children to have impaired sodium resorption. So when this happens, polyuria develops. These children basically behave like they're on a diuretic. In addition, they can develop hypokalemia from the high urine output. It can take potassium with it, so this can lead to muscle cramps. And then finally, these children will develop a metabolic alkalosis. They have essentially a contraction alkalosis, just like anyone who is taking a diuretic. These disorders do not cause hypertension, so don't confuse them with any of the inherited disorders we just talked about that can cause low renin hypertension. Bartter syndrome is a defect in sodium resorption in the thick ascending limb. It involves the same pump that is normally inhibited by loop diuretics. This presents in childhood with polyuria. Because patients are urinating a lot, they're thirsty all the time, so the parent may notice polydipsia. And often these children have nocturia, meaning they wet the bed, and that's because of the high volume of urine produced at night. They develop a contraction metabolic alkalosis and hypokalemia. And then finally, an important point is that this pump is not only important for sodium resorption, but also calcium resorption. So these children have a high urinary calcium because the thick ascending limb cannot absorb calcium. And that's one of the ways you distinguish this disorder from Gittleman syndrome, which we'll talk about in just a second. So Gittleman syndrome is defective sodium resorption in the distal tubule, shown here in my drawing. It's similar to the effects of being on a thiazide diuretic. Just like Bartter syndrome, it presents in childhood with polyuria, polydipsia, and nocturia. These children also can develop a contraction alkalosis and hypokalemia, but importantly, they will have low urinary calcium, not high, and that's because the distal tubule normally secretes calcium, and it's not going to do that normally in children with Gittleman syndrome, so they will have a low urinary calcium. I'll finish this video by discussing two special points related to metabolic alkalosis, and the first one is the urinary chloride test. Measurement of the urinary chloride level is a rarely used test when patients have metabolic alkalosis of unclear etiology. The idea here is that when patients are losing gastric acid, they lose chloride. As a result, the urinary chloride will be low. So if you're not sure why a patient has metabolic alkalosis and the urinary chloride is low, that suggests that that patient is losing HCl from the GI tract, either from vomiting or nasogastric suctioning. And this is really the major utility of this test. If the level is low, then that tells you there's gastric acid loss. If the level is not low, it's hard to know what to do with this test. Other causes of metabolic alkalosis have variable findings. For example, immediately after you give a diuretic, the level will be high, but the level can also be high in other circumstances, so it's hard to make a diagnosis if the level is high. The main utility is that when it's low, there's some cause of gastric acid loss. And then finally, sodium chloride fluid administration resolves most forms of metabolic alkalosis. Sodium chloride fluid contains sodium, chloride, and free water, and I talk about the fluid in more detail in the video on fluids, but it resolves metabolic alkalosis if the metabolic alkalosis is chloride responsive. So for example, patients who are volume depleted from diuretics, they will get better if you give them sodium chloride in terms of their metabolic alkalosis. Patients who are vomiting can have a very high bicarbonate from alkalosis, but if you give them sodium chloride fluid, it will get better. So in most of the common reasons for metabolic alkalosis, things like volume depletion and vomiting, the metabolic alkalosis gets better when you give fluids. It doesn't work in some of the rare causes of metabolic alkalosis. So if the problem is hyperaldosteronism, then the metabolic alkalosis is not going to get better. If a child has Bartter or Gittleman syndrome, the metabolic alkalosis is not going to get better. And of course, in patients with heart failure and cirrhosis, you never want to give those patients sodium chloride fluid because they are volume overloaded. Heart failure patients have pulmonary edema, cirrhotic patients have ascites, so sodium chloride fluid administration is generally contraindicated in these patients. Bottom line here, though, is a key step in evaluating any patient who has a metabolic alkalosis of unclear cause is to determine the volume status. You want to look at the patient and see if the mucous membranes are dry, see if the blood pressure is low, see if the jugular venous pressure is high or low. Because if you determine that that patient is volume depleted, then you probably have made the diagnosis of the cause of their metabolic alkalosis. It's a contraction alkalosis. So anytime a patient has a bicarbonate level that's elevated, one of the first things you want to do is determine the volume status, because this gives you important clues about what may be causing the metabolic alkalosis. And that concludes our video on metabolic alkalosis.